A question I'm often asked about is how long can you restrain someone for? And this short presentation is just going to look over a couple of issues concerning the length of time that someone is restrained. So the basic answer is only as long as is necessary, reasonable and proportionate, take into consideration all the medical safeguards. So let's have a look at two recent cases that I've been involved with. One is an adult in a clinical setting and one is a child in a school setting. The adult died and the child was injured and claims that their restraint amounts to abuse because of the time that it went on. Now, if we look at some of the history in relation to timings, in 1995 a clinical setting suffered the loss of patient David Bennett following a restraint for approximately 25 minutes by clinical staff at the Norvik Clinic. The independent inquiry report produced in December 2003 found that we also conclude that the restraint continued for substantially longer than was safe, and that was at 25 minutes. The inquiry also concluded at page 53 of the report, people should never be held face down in a prone position for more than 3 minutes. Now then, in 2002 we've got a key document, the Guidance for Restrictive Physical Interventions, how to provide safe services for people with learning disabilities and autistic spectrums, and this was jointly published with the Department of Health. The foreword states that it's been developed with considerable help from the health, social care and education sectors, and the summary states that the purpose of that guidance is to ensure that restrictive physical interventions are used as infrequently as possible, that they are used in the best interests of the service user, and that when they are used, everything possible is done to prevent injury and maintain the person's sense of dignity. So that was as far back as 2002. In more recent years, the Department of Health, the Home Office and the Ministry of Justice have produced a combined paper via the Independent Advisory Panel on Deaths in Custody for Common Principles for Safer Restraint. And some of these issues are that only trained and authorised staff may apply restraint. Staff must understand the non-physical and physical techniques they will use. They must have been trained in the safe application of those techniques. Their skills in both de-escalation and approved techniques must be maintained through regular training. If 3 or more staff are actively involved in a restraint, then one of those staff must be in control of the restraint, and they're known as the controller, and it must be clear at all times to all involved in the restraint who is the controller. At the start of an episode of restraint, the staff member responsible for protecting the detainee's head, neck and breathing will assume the role of controller regardless of rank. The controller must have authority to order the alteration or release of any of the restraint holds. All approved restraint techniques must take into account the possibility that underlying disease may render an individual more susceptible to adverse effects and possible death. The vital signs of the restrained individual must be assessed as soon as possible after the commencement of the restraint, so that's actually during it. These assessments of vital signs must be repeated frequently throughout the period of restraint and the results made known to the controller. If the restraint is planned intervention in an institution with trained healthcare staff, then they must be present throughout the period of the restraint. All episodes of restraint should be video recorded if at all possible. Detailed and accurate records of all incidents of restraint must be maintained and analysed. This data should be used to review techniques and practices and to inform staff appraisals, training and development, and debriefing procedures must be established and followed by all those involved. So what happens to the body during restraints? Well, physical changes can include blood pressure to the head significantly increasing. This can cause capillary damage and potentially a stroke, regardless of the age of the person. Oxygen saturation reduces throughout the body, and this can cause organ failure or hypoxic brain damage. The body temperature can significantly increase and cause fever fits, and the body also increases its release of adrenaline releases and sugar release as well. Now, any of these can trigger underlying medical conditions such as asthma, diabetes, sickle cell, epilepsy, etc. And a key thing is that restraints are never safe. Every restraint carries risk, and whether that risk is to the members of staff or the service user. So it is essential that if a restraint is necessary, that the actual restraint is for the shortest possible amount of time. that it's conducted by staff trained in safer restraint techniques, that the restraint is without any interference with the respiratory system, and the respiratory system is the entire torso, neck and face, with the significant increase in medical observations during and post-intervention, and where possible a healthcare professional assesses the restrained person during and after the restraint, that the incident is fully debriefed post-event by a manager trained in the assessment of physical restraints. It's no good if the manager assessing this has no knowledge in relation to physical intervention, restraint techniques and the issues and risks connected with that. And ultimately, if you want any guidance in relation to physical intervention, whether you're in the education sector, the care sector, the clinical sector or the custody sector, please do not hesitate to make contact.